laboratory, and suddenly the patient moves. You're giving everyday anesthesia, isn't it? So you're
Yes.
using neuromuscular blocking agents and hypnotics and all these things you're using. Inhalation anesthetic agent, IV anesthetic agent, opiates. And suddenly if the patient in between moves a little bit, there's a small movement of his hand. Now, so that what you will do now?
Um, if we have a TOF monitor, we can check TOF,
So
see that
patient moving means
patient
what?
moving. So with
Definitely, the patient is very light with the neuromuscular blocking agent, isn't it? You don't require a tough monitor. If you have tough, quantitative monitoring is always best. Suppose you are not monitoring, patient is moving means definitely he is coming out of neuromuscular blocking agent.
neuromuscular, yes,
What you will do now? What is your immediate reaction to that particular situation?
to give the neuromuscular blocking agent.
Previously, you also would like to give a neuromuscular blocking agent, is it?
Sir, I would increase the depth of anesthesia,
Yeah,
sir.
very good. So, why a patient is moving? That first you should always think about. Listen, patient is, if his depth of anesthesia is adequate, you would not have moved. Even though the neuromuscular blocking agent may be wearing off, but as long as the depth of anesthesia is good, that means he's not feeling anything of what is happening. And he's in the deep plane of anesthesia, so he won't move. If he is moving means first thing, Siddharth on the screen, you should always realize that he is light as far as his anesthesia is concerned. Of course, first thing what you have to do is immediately it all depends on what kind of surgery that you are doing. Suppose if it is a neurosurgery, or if it is an intraocular surgery, or surgery of the ears, where a plastic surgery, where slight movement of the patient can produce disasters. In such situations, first thing what you have to do is you just give a top-up dose of neuromuscular blocking. But in an abdominal surgery, slight movement doesn't matter at all. Even the surgeon may not even know what is happening. In such situation, first thing is you should first try to increase the depth of anesthesia, and then you give neuromuscular blocking agent also. But first thing is, and in the first situation also, I told you that in a neurosurgery or where you don't want any movement, there also the first reaction is to give neuromuscular blocking agent and then increase the depth of anesthesia.
Yes.
But here in the where open laparotomy, all the intestines are out and they are just anastomosing the intestines or doing something where they hardly require any muscle relaxation. There, your first reaction is to increase the depth of anesthesia and then go for
Yeah.
adding a supplemental dose of neuromuscular blocking agent. Now, why it is important to increase the depth of anesthesia rather than just keep giving neuromuscular blocking agent? So, what is the idea here?
So such that the patient doesn't have any uh,
The patient doesn't perceive the stimulus.
stimulus and
So what do you mean by perceive the stimulus means what? What
the
is that?
memory behind it.
Yes.
The memory behind the
So patient may be aware of what is happening. That is very important, isn't it? Awareness under anesthesia. That is what is the most important thing. So till the neuromuscular blocking agents were introduced, there was nothing called as awareness under anesthesia. It all started after the neuromuscular blocking agents were introduced. Because people started giving neuromuscular blocking agents to make the patient not to move and make him still. So they were not knowing about patient is moving because of lack of depth of anesthesia. So that is most important. I don't know whether you people have seen one movie is there in English movie is there, an American movie called Awake. You heard about this movie? Have you seen this? It's available in YouTube. So it starts with like, under general anesthesia, even in America, So almost nearly 10 million people are anesthetized every year. Out of that, 25 to 50,000 patients will be aware of what is happening and will be awake during anesthesia. You can imagine this can occur in highly monitored patients in America, where we hardly monitor depth of anesthesia. You can imagine. So, and in that, actually, the patient would be subjected, the hero would be subjected for a heart surgery, a replacement, heart replacement, or heart transplant. The nurse there will be in love with the surgeon, and nurse will be his wife. They'll be discussing how to, end his life for the surgeon, and that is the mood. And
Okay.
outside, his mother will be waiting. This fellow will be awake, and he'll be able to listen to all their discussions, and he'll be, crying actually. And they transplant the heart, it starts beating, they inject a particular toxin, stops beating, they come and announce outside. Anesthetist would be, outside actually, would not be inside at all. Even in America, this is a, and outside when it was announced, what happened when they say that the heart that was transplanted is not functioning. No, it is just like a Hindi cinema, it ends like the mother calls her husband, who is a cardiac surgeon. He comes, and then in the meantime, she commits suicide, and then he should have written, "Please transplant my heart." And immediately her heart will be transplanted, and police will be called, and these two people will be arrested later at the end of once the patient comes out of anesthesia, he will tell everything. So that is what is awake, and awareness under anesthesia is very important. It all started once the neuromuscular blocking agents were introduced to the world. So, do you think that neuromuscular blocking agents are anesthetic agents, or
No,
they are
sir.
No,
not
sir.
agents?
No, sir.
They are not anesthetic. Very good. So, fantastic. So, why do you think that they are not anesthetic agents?
They only help. They only help us in a way to suppress the
And
any
to
muscle.
relax the muscle so that the surgeon is helped, isn't it? For you
Yes.
to intubate the
Like
patient, for
relaxation.
the surgeon to have enough of
Relax.
relaxation, that is what is the requirement of neuromuscular blocking agents. Why do you think that they are not anesthetic agents as such? What is the
Because it
reason?
provide enough narcosis or analgesia.
No, do they eh, cross the blood-brain barrier? Do they enter the brain? Because general anesthesia occurs where? It occurs in the brain, isn't it? So,
Yes.
if the anesthesia to occur, if it is an anesthetic agent, so it has to cross the blood-brain barrier and enter the brain, and then it has to act on the brain and suppress the activity of the cortex so that patient is totally unconscious. The reversible state of unconsciousness is what we call it as anesthesia. So why neuromuscular blocking agents do not cross the blood-brain barrier? What is the reason? They don't cross the blood-brain barrier, so no question of them acting on the brain and then producing anesthesia. Because they are quaternary ammonium compounds, and because that quaternary ammonium compounds are hydrophilic, in order to cross the blood-brain barrier, the drug has to be hydrophobic or lipophilic. These are hydrophilic, not hydrophobic or not lipophilic. They cannot cross the blood-brain barrier. That is why they are not actually anesthetic. They only supplement your anesthesia. What we usually do is a balanced anesthesia technique. Every day you are doing is a balanced anesthesia technique because there are many requirements of anesthesia. All these requirements of anesthesia you are able to fulfill by using a certain drug for each requirement, so that you balance the dose of these drugs so that the patient is very well anesthetized and all the requirements of anesthesia are met. And once the surgery is over, you can make the patient to come out of the anesthetic agents, isn't it? So that is what we use it as the balanced anesthesia technique. So what are the, as such, what are the requirements of anesthesia as such? What are the requirements of anesthesia?
For a good anesthesia, there should be enough narcosis, good analgesia,
Analgesia.
and enough
Narcosis and analgesia, okay. One is unconsciousness and
Unconscious.
amnesia.
and
You want the patient to recall the events, isn't it? So if the unconscious, we should have amnesia. Then, as you said,
amnesia should be there.
analgesia.
Analgesia should be there.
Then, what is the fourth requirement?
And muscle relaxation.
Muscle
So
relaxation.
relaxation.
So muscle relaxation. What is the fifth requirement? It's the appendation of reflexes. Appendation, like for example, the surgeon is pulling a viscera, the patient should not go for severe bradycardia and arrest. So these are some of the cardiac reflexes. There's no surgeon is operating and the epilocardiac reflex should not get activated. Child or adult patient going in for bradycardia and arrest. So these appendation of many of these reflexes are very important. Finally, the homeostasis of all the systems of the body to be maintained. Like, there should not be hypotension, there should not be bradycardia, and respiratory system, should be adequately suppressed if the patient is on paralyzed or if the patient is breathing, he should be able to breathe well. There should not be hypoxia, hypercarbia. So all these are homeostasis of the all the systems of the body. So these are actually the requirements. So, for unconsciousness, use hypnotic agents, either IV hypnotic agents like only IV hypnotic agents like in TIVA, and inhalation also when you are not using TIVA. So that will maintain the unconscious state of the patient. The other important thing is amnesia, of course. The best amnesic agents are what? Which are the drugs which can produce the best amnesia?
Sir, metazolone and
Benzodiazepines.
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 They produce anterograde amnesia. So we always use benzodiazepines because they produce, once they are injected, once they start acting, till their effect is there, the patient may not remember much of what is happening. So that is what is called as anterograde amnesia. And analgesia, majority of the times, either we use non-narcotic analgesics or narcotic analgesics. Or what we call it.
Pentamorphine.
Yeah, and for muscle relaxation, separately you'll be using muscle relaxation. And for appendation of reflexes, you can use many of the, and maintaining homeostasis, you can use many of the drugs. And like vasopressors, maybe anticholinergics. So that's how you always use. And muscle relaxants are part of your anesthesia. That's all. They are not basically, they are not. So that is what is very important. And the other important thing is, we know that anesthesia was started in 1846. So before
Yes.
that also, people were anesthetized, but 1846, October 16, that is the day we always celebrate as
E13.
World Anesthesia Day.
World Anesthesia Day.
Officially, anesthesia was introduced to the body. So for a long time, only inhalation anesthetic agents, or then later intravenous anesthetic agents from 1930s when Rapentone was used or introduced, we are using, and we are not using any neuromuscular blocking agent. And when the first neuromuscular blocking agent was introduced,
1590.
first
That is
neuromuscular blocking agent. Till 1950s also no neuromuscular blocking agent. And Rapentone was introduced by Lundy and Waters in 1933. Till
1942, sir.
very good, 19,
42.
yeah, very good, 1942. So which muscle relaxant was introduced in 1942?
Curare.
Detubercularine, DTC,
The
D-tubocurare.
Detubercularine
uh,
to appendicit.
popularly known as DTC, Detubercularine. That was introduced in 1942. And who introduced DTC for anesthesia purpose?
Griffith.
A very good, Griffith and Johnson. David Griffith and Johnson, they introduced in 1942. From which country they belong? Belong to Canada. They were Canadian anesthesiologists. And of course, it was a revolutionary introduction, isn't it? Till then, there was no neuromuscular blocking agent. All the requirements of anesthesia were by either majority by inhalation anesthetic agents. The patient was moving means that he is lighter with inhalation. They used to increase the depth of increase the concentration of inhalation agent still 1942. And surgeons used to have a lot of problems because relaxation was not there. So that's how DT Becquerel Curer uh, was used as an arrow poison in Southern America in jungles. So they used to apply it to the tip of the arrow and then they used to shoot the arrow. And once it used to hit the animal, get paralyzed. That's how they could kill the animal. Later, when these animals were made to be ventilated by using a tracheostomy and then they were ventilated, then they came out alive. Then they realized that these can be used for the anesthesia purpose. As that's how it was introduced. TTC was introduced. No, but there was a paper that was introduced in 1954 by Beecher and Todd. Actually, Beecher and Todd actually did a study comparing almost nearly 550 patients in each group. One group where neuromuscular blocking agents were used, another group neuromuscular blocking agents was not used. Mortality where neuromuscular blocking agents were used was 6 times the patients in the group where neuromuscular blocking agents were used. Then they concluded that neuromuscular blocking agents have got no role in anesthesia. And they kill the patient. Mortality is very high. They should not be used. And why that was the situation during those times when BTC was introduced and mortality was be on the high. Why do you think?
Excessive dosage,
No enough
or
preparation, pre-preparation. So,
So why do you think that dosage, excessive dosage, and they used to give very small dose just to produce relaxation of the abdominal muscle, and they were not mechanically or manually ventilating the patient. They were allowing the patient to breathe
so
spontaneous
they,
breathing only, just to relax the abdominal muscle so that better relaxation would be there. And another thing is they were not giving any reversal agents like minoxidil and anticoagulants. And when do you think that the actual reversal started of these neuromuscular blocking?
so after the patient would have gone into apnea.
No, 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 no. When they started using neostigmine and atropine or glycophage for reversing the effects of neuromuscular blocking, which year I mean? It was 1952. Just imagine from 1942, DTC was introduced. The DTC was not being reversed till 1952. The effects of DTC, invariably, the effects of DTC used to be there throughout this surgery and allowing the patient to breathe spontaneously in the postoperative period. Residual neuromuscular palsy used to be there in the new postoperative period. The patients used to die of hypoxia, hypercarbia, respiratory stenosis, metabolic stenosis. All these things used to be there. So that's how, and there was no monitoring, no monitoring. And when was the first monitor was introduced and who introduced the monitoring? Neuromuscular monitor. Okay,
Daniel Bove.
with, Churchill Davidson introduced first neuromuscular monitor that was in 1958. Till 1958, there was no neuromuscular monitoring. Only in 1958, the first neuromuscular monitor was introduced by Churchill Davidson. So, and Churchill Davidson said that Every patient who has been given neuromuscular drug, blocking drug, will be monitored with a neuromuscular monitor, and that can produce more safety for patients with this neuromuscular blocking. Those will conclusion will be put into the paper regarding the monitoring. So nowadays, actually, ideally speaking, monitoring is very important. The quantitative monitoring is more important than the qualitative monitoring. The subjective monitoring is not good. It should be an objective monitor using a neuromuscular monitor. Not objective monitoring also should be quantitative monitoring rather than qualitative monitoring. We'll come to that later. So that is what is very important. And when was succinylcholine introduced?
Saxamethonium was introduced in the year 1957, sir.
In 1952. And who introduced succinyl?
That was by Bove, sir.
That was by Folds and Bobbitt. Actually, Folds introduced it. Bobbitt studied the succinylcholine, pharmacology of succinylcholine.
She's
Folds,
also.
usually you can remember Folds and Bobbitt. Bobbitt used the succinylcholine. That was 1952. So first, was a non-depolarizing muscle relaxant that was introduced. Later, a depolarizing. And when was that amino steroid, the muscular blocking agent, pancuronium was introduced? 1967,
1967.
67.
pancuronium was introduced. And lecuronium and atracurium were introduced in 1980s. Lecuronium and atracurium were introduced in 1980s. And your evacurium, cisatracurium, and acuronium were introduced in 1990s. Cisatracurium, evacurium, and rocuronium. Presently, what we use, presently we use, you know, depolarizing muscle relaxant succinylcholine is still being used, though it was used in 1950. I think you people are using succinylcholine, but they're not
Yes, sir.
Yes, sir.
they're using that. The other important drugs, neuromuscular blocking, what we are using, non-depolarizing muscle relaxant, like we are using ecronium. Pancuronium is still being used by cardiac anesthesiologists because for its long duration of pancuronium, lecuronium, then the rocuronium, and tracurium and cisplatin. These are the non-depolarizing relaxing therapies. So you have to know about these. You have to know about the depolarizer in succinyl, non-depolarizer, pancuronium, lecuronium, lecuronium, and these are the drugs that are kept in the form of very these drugs are asked. The key drugs you have to know. So before actually going in for the actual pharmacology of these drugs, so you have to know about basic anatomy and physiology of the neuromuscular junction. Unless you know about the basic anatomy and physiology of neuromuscular junction, you will not be able to understand the pharmacology of neuromuscular blocking rate. Can you just, Siddharth, can you just tell how muscle contraction occurs?
Sir, so the
From where a signal will come?
uh, presynaptic nerve terminals.
So before that, the signal has to come from, oh, isn't it?
Yes,
So from where the first signal will start off.
the
So signal to initiate a muscle contraction. So suppose I want to do something. So from where I have to get the signal so that I suppose I want to do a purposeful movement. For any purposeful movement, I'll have to do muscle contractions. I have
yes,
to hold something. I have to lift something. So my muscles have to work. For that, I have to get a signal from where?
from
From my
the
brain, isn't it?
from the brain.
Yeah, which part of the brain?
Uh,
From the motor cortex, where motor neurons are there, isn't it? From motor cortex, the signal has to start, and the signal has to reach again which neuron? Again, this
Motor.
motor neuron signal has to come down and reach which neuron in the
Uh,
spinal cord. It has to reach the spinal cord, isn't it?
yes.
And what neuron in the spinal cord? Again, a motor neuron in the spinal
Motor
cord,
neurons.
Neurons.
isn't it? The motor neuron in the spinal. Where are these motor neurons in the spinal cord?
Posterior column.
Posterior column.
Posterior is sensory.
Anterior.
The anterior ventral horn.
Anterior.
Ventral horns. You have the ventral horns. Posteriorly, it's you have the sensory. Anteriorly, it is always the motor. So motor neurons are concentrated in the ventral part of the spinal. So once it reaches, now it again produces another signal, isn't it? This signal passes through the axon. Every motor neuron has got its own axon. And the signal, electrical signal passes through this axon and reaches the nerve terminal, isn't it? There are axon terminal. And what happens to this axon terminal usually? Is it a myelinated axon or non-myelinated axon? The motor neuron.
Myelinated.
It's all myelinated, isn't it?
All
Yeah,
myelinated.
yeah, alpha fibers. We were discussing when we were discussing about local anesthetics. We were always telling, yeah, alpha is the one. They are the motor fibers. So all these are myelinated fibers. They are very thick fibers. Their conduction velocity is very fast, and they are the ones. These are the axons, which as soon as each axon enters the muscle fiber or the muscle, actually, not the muscle fiber, muscle. What happens to this myelin sheath?
Contracts.
No, it loses its myelin sheath. Once it enters the muscle, the axon will lose its muscle, the myelin sheath, and it starts dividing into multiple nerve fibers, branches. Each axon will produce multiple branches, and each of these branches will supply one single muscle fiber. Each of these, and each axon will divide into how many branches for majority of the skeletal muscles?
Three.
Each nerve terminal will supply a single muscle cell.
So that is nerve terminal. That is a branch. That is not the axon. Axon will divide into multiple branches or nerve terminals. After losing the myelin sheath, it starts dividing. It divides into multiple branches. And these multiple branches, each one is going to supply one muscle fiber. That is what I told. So each axon is going to multiply or branch into how many branches? For majority of the skeletal muscles.
It will multiply to through peripheral nerves, sir.
It
Not
into
understand. Each axon, I am telling you, because each nerve will have multiple axons inside them. I'm talking about a single motor neuron
motor.
giving one axon. Axon is entering the muscle as such, loses its myelin sheath, then it divides into branches because anatomy and physiology of neuromuscular junction is very important to understand the pharmacology. So there is no point in going into the pharmacology as such without understanding the basic anatomy and physiology. That is the basic knowledge is very important. So each axon will divide into nearly 2,000 branches. And each branch will have a nerve terminal which supplies one muscle fiber of that particular muscle. So now you can imagine one motor neuron in the spinal cord having its axon, having its multiple branches, supplying multiple muscle fibers. And this whole thing is called as what? The muscle fibers, the multiple branches of the axon, single axon, and a single motor neuron. What is this whole, thing is called as?
Motor units.
It's called as
Motor.
a single motor unit.
Single motor unit.
So sometimes you may be asked, what is a motor unit? Motor unit mainly consists of the motor neuron that is there in the anterior part of the or the ventral part of the spinal cord and its axon, and then its branches, and each branch supplying each branch supplying one muscle fiber. So the axon supplying multiple muscle fibers and the motor neuron, the whole thing is called as a motor unit.
Right.
Why we should know about the motor unit is one single motor neuron getting stimulated, sending its electrical signal, it is going to contract all those muscle fibers which are supplied by that particular motor neuron. So that is what is called as a motor unit.
Right.
So that is very, very important. And when you want a good muscle contraction, all the motor units supplying that full muscle have to be stimulated,
Have to be stimulated.
and you can have a good muscle contraction. That is what, when we discuss about neuromuscular monitoring, a supramaximal stimulus. You have to use a supramaximal stimulus. It is not just a maximal stimulus or less than maximal stimulus. You have to see that all the motor units supplying that muscle have to be stimulated when you are using a neuromuscular monitor. So for that, this motor unit concept is very important. And is there any particular group of muscles where the axon has hardly one or two branches and supply the muscle fibers?
Cardiac.
There are no 2000 branches. It's just one or two branches, and these branches are going to supply each branch supplying one muscle fiber. So that the motor unit will have less number of muscle fibers. Which group of muscles are these? Again, it's very important for us to know anesthetic implications. The extraocular muscles and small muscles of the hand, where fine movements are required. Small muscles of the hand, the intraosseous nerve, plus most important thing is the extraocular muscles. Because these extraocular muscles, one thing is each muscle fiber will be supplied by a single axon, or one axon dividing into two or three branches and supplying the two or three muscle fibers. Because more concentrated supply of the axon,
Small
there
and
one. The second thing is here the innervation can be multiple innervation for the same muscle fiber. In other skeletal muscles, there will be one muscle fiber, one
One.
neuromuscular junction. Whereas the extraocular muscles and small muscles in the hand, they are multiply innervated, each muscle fiber. Each muscle fiber can have multiple neuromuscular junctions. And this is very important so that, to keep the eyeball in a particular position, it is very important to have the specialized type of neuromuscular supply for these extraocular muscles. And another important thing about these extraocular muscles is when a signal comes, when they get stimulated or activated, they contract very slowly and relax very slowly. Not like the other group of muscles where the contraction is brisk and relaxation is brisk. Here they contract very slowly and they relax very slowly. And because of that, they maintain a posture like a sustained contraction of the extraocular muscles, or a sort of contracture of the extraocular muscles. And that's how, the eyeball is always kept steady. It is not moving much. If you want to look at a particular point, you can even just keep looking at a particular point. Your eyeball will not move at all. It will be very kept very steady. And this is mainly because of this slow contraction and slow relaxation of these extraocular muscles because of their specialized neuromuscular junctions, multiply innervated. Now, why should you know about this particular thing about the extraocular muscles? What is the anesthetic implication of this? What is the anesthetic implication of this particular anatomy of the neuromuscular junction of the extraocular muscles?
If the eyes are fixed under anesthesia, then it means the blockade is
That is, when you are using inhalation anesthetic agent, stages of anesthesia, and all. That is nothing to do with the neuromuscular blockade. I'll give you a clue. The effect of succinylcholine on extraocular muscles.
increase intraocular pressure.
Yeah, very good. So why increase in intraocular pressure occurs because of succinylcholine when it acts on these extraocular muscles? Because you know that they are specialized muscles, they produce, the contraction is very slow, relaxation is very slow. When succinylcholine acts on these muscle groups, it produces
Prolong,
very sustained and
sustained,
prolonged
prolonged.
contraction, and the eyeball gets squeezed by these extraocular muscles. Because the eyeball gets squeezed with the extraocular muscles, the intraocular pressures can increase by 15 to 20 millimeters. So that is why, you may be asked, especially when you have given a succinylcholine vial, you may be asked why it produces rise in intraocular pressure. So that is
Okay,
what
sir.
is very important. Okay, so now we have come up to in our anatomy, the nerve endings are there. Now, what are these nerve endings? These, once they lose the myelin sheath, they branch out, and each nerve ending is again a specialized unit of the axon. What is the anatomy of this nerve ending? Just briefly, you can just tell about the anatomy of the nerve ending, what will be there. And because one thing is the nerve ending, and opposite to the nerve ending, you have the muscle membrane, which is a specialized part of the muscle membrane, which is called as the the
Motor,
muscle end plate.
motor end plate.
It is called as a motor end plate.
Motor
And
end
plate.
plate.
Motor end plate. The nerve ending opposite to it is motor end plate. The whole thing will be covered by a Schwann cell membrane.
Trans-
So, what is the basic anatomy of the nerve terminal or the nerve end? Motor nerve ending.
on one end, we have it's composed of three parts, sir. On one hand, we have the presynaptic nerve terminal. So, in the center is the synaptic.
No, I'm
Is
not talking about the whole muscular junction, neuromuscular junction.
okay, sir.
I'm asking you to talk about the nerve ending itself. Motor nerve ending.
The presynaptic nerve
Adilla.
terminal.
That is what the nerve ending.
Okay, sir. In
What
the
is
end.
present inside the nerve ending?
Okay, sir. The motor end plate in itself is it meets with
Again, you are getting confused. I'm not talking about the motor end plate. First, nerve ending, then the synapse, and then the motor end plate.
okay, sir.
First, you talk about the nerve ending and what is present inside the nerve ending.
Okay, sir. In the motor end plate, it contains
Again, you are getting confused.
A motor
Not
end
the
plate.
motor end plate. Motor end plate is
Motor.
after the synapse. You have the nerve ending, then the synapse, and or the space between the nerve ending and then the motor end plate. And after that motor end plate starts. What is present inside the nerve ending, which is very, very crucial, very, very important.
Sodium channels.
No, no, you have acetylcholine
Acetylcholine.
acetylcholine.
stored in
Okay,
the
sir.
vesicles,
The
Vesicles.
synaptic left. Okay, sir.
isn't it? So acetylcholine is present and it's
The
stored in the vesicles
Vesicles.
okay,
inside the
sir.
nerve ending.
Okay, sir.
So there are two different parts of these acetylcholine vesicles. What are these called as? They are called as reserve acetylcholine vesicles and then immediately available acetylcholine vesicles. I don't know whether you read about the neuromuscular junction anatomy and physiology. That is the most important thing. Unless you know about the neuromuscular anatomy, there is no point in discussing about the pharmacology. That's why even in your textbook, first they would be giving anatomy and physiology, and then the pharmacology, and then the monitoring, and lastly reversal, isn't it? So the motor nerve ending is a specialized unit of the neuromuscular junction, and it mainly consists of the acetylcholine, which is stored in vesicles, and there's two groups of vesicles. One is the reserve group.
Reserve.
Another group is immediately available acetylcholine vesicles. And these immediately available acetylcholine vesicles are just behind an active zone of the nerve ending, which is called as an active zone, or sometimes also called as thickened zones. And just behind these active zones, these immediately available acetylcholine vesicles will be there. And so whenever the electrical signal comes to the nerve ending, now what happens to these vesicles? Now the vesicles have to open and then release acetylcholine into the synapse, isn't it? How this occurs? How does this process occur?
It
What
occurs
is
by
required
the
for movement of the acetylcholine
uh,
to reach the active zone and then release their acetylcholine?
it occurs by the hydrolysis of acetylcholine by the cholinesterase enzyme.
Okay, you are totally getting confused. You are talking about after the release of acetylcholine in the cell, their hydrolysis will occur. But acetylcholine has to move in the nerve ending towards the active zone and then it will get released. And what makes it release? This is again a very important anesthetic implication is there. What has to enter inside the nerve terminal to release acetylcholine?
Sodium.
Sodium channel.
No, no, no. Some other electrolyte.
Potassium.
Yeah.
One more electrolyte you can just tell.
Chloride channels.
The calcium.
Calcium.
Calcium channels.
Other than calcium, you are telling about everything, sodium, potassium. So, right. So the calcium channels have to open, which are
Yes.
present at the nerve ending. The calcium has to enter inside the nerve ending and it has to activate a transport protein inside the nerve ending. This transport protein will bring the vesicles very close to the active zone, and through the active zone, acetylcholine will be released into the synaptic cleft. And this synaptic cleft is between the nerve ending and the specialized motor end. And what is this distance of the synaptic cleft?
20, 20 nanometers.
50 nanometer.
50 nanometers.
And this 50 nanometer will be there. And once acetylcholine enters here, now what happens to this acetylcholine? What it does?
Uh, the sodium snare complex.
What happens to this acetylcholine? What it does? You can just simple way of you can answer. It has to act on the motor
It,
plate, isn't it? And
it goes and gets attached to the receptors.
yeah, where are these receptors on the motor end plate? And what kind of receptors they are called as?
Uh, nicotinic receptors.
Yeah, nicotinic receptors, isn't it? So they are nicotinic receptors that are present over the motor end plate. Where exactly they are present over the motor end? What is the now the structure of this motor end plate? What it contains?
Postsynaptic membrane.
No, it consists of multiple clefts, isn't it?
Synaptic clefts.
It will it will have multiple clefts, the primary cleft and the secondary cleft. Isn't it? So all the shoulders of these primary and secondary clefts, these the receptors, the nicotinic receptors are concentrated there. So that immediately the acetylcholine that is released directly can act on these receptors. And how many different types of receptors are there actually? These nicotinic receptors at the motor end. What are the different types of nicotinic receptors?
It's a 5 alpha beta.
No, what are the different types of receptors? Then you can talk about individual receptor, what subunits.
Uh, it is a 5, 2 subunits, 5 subunits, and
There are actually two kinds of nicotinic receptors can be present. One is the fetal type and an
It
adult.
has a net with
Adult type of
endpoints and roots.
receptors and fetal type of receptors. What these adult type of receptors, how many subunits are there? Adult type of receptor. What is the difference between adult type of receptor and the fetal type of receptor?
adult adult type has 5 subunits.
Okay. Both adult and fetal type will have five subunits.
5 subunits.
So what are these different subunits in adult type? What are the different
Alpha, beta, delta, epsilon, and
how many alpha
2
subunits?
alpha.
Two alpha. How many beta?
One
2
beta,
alpha, 1
One
beta,
alpha,
one epsilon,
1 delta,
one
and 1
delta,
epsilon.
and one
delta,
epsilon.
and one epsilon. So totally five.
5.
So that is in adult type of nicotinic receptor. So what about the fetal type of nicotinic receptors that are present only in the fetus, and also they can be present later whenever there is denervation is there. They also can be formed. Fetal type of receptors can be formed, especially whenever a muscle gets denervated. They are also called as extrajunctional receptors. That is again very important for us to know, especially when fexinelcholine is used in these patients who have denervated muscle groups. What is different in these extrajunctional receptors or otherwise the fetal receptor? Which subunit will not be there?
Epsilon subunit
Instead of
is not there.
epsilon, there is a gamma subunit.
Gamma subunit.
That is the basic difference between an adult type of nicotinic receptor and a fetal type of nicotinic receptor or extrajunctional nicotinic receptors. And what about their function as such? Functional difference. Structural difference, you just said. What is the functional difference of these two types of receptors? Now, one thing is that the adult type of receptors, they open up and their channel is very wide when they open. The pentameric structure is there. So inside the pentameric structure is the channel.
Yes.
Once it opens very wide so that sodium can enter, calcium can enter, potassium can come out, chloride can enter or come out. So all these things can occur. Whereas with the fetal type, the opening is very narrow. It can allow either sodium to enter or potassium to come out. That is one difference. The second difference is the the effect, the duration of opening is much longer with the fetal type or extrajunctional. They keep they open for a long time. Whereas the junctional receptors or the adult type of receptors, they open for a short, very brief time. That is second difference. The third difference is their life. The junctional receptors or adult type of receptors, they can live for 7 days after their synthesis. Whereas the extrajunctional receptors, they die after 24 hours. Their life is very. One more difference is the junctional receptors will be activated by succinylcholine, sorry, by acetylcholine. and also by succinylcholine. Even the extrajunctional receptors, they also will be acted upon by acetylcholine and succinylcholine. Whereas the extrajunctional receptors are resistant to the effect of non-depolarizing muscle relaxants. Non-depolarizers cannot act on the extrajunctional receptors. That is why when extrajunctional receptors are there, the requirement of non-depolarizers will be increased because they are resistant to the non-depolarizing muscle relaxants. Whenever there is a denervation has occurred, a lot of extrajunctional receptors are formed. So they are resistant to non-depolarizers. The requirement of non-depolarizers will increase in those muscles. Whereas they are highly sensitive to depolarizers, like succinylcholine. And even they are sensitive to choline also. They need not be a succinylcholine or acetylcholine. Even choline, which is a product of acetylcholine and succinylcholine, can open these receptors. So once the receptors get opened, a lot of potassium will come out. That you must have known about hyperkalemic response with depolarizing muscle relaxants because of the presence of more number of extrajunctional or fetal type of receptors, isn't it? So that we will come to, we'll discuss when we discuss about succinylcholine. So this again is a basic anatomy of these receptors you should always know. The difference between extrajunctional receptors and junctional receptors. Okay. Now, once this acetylcholine acts on the receptors, it will open the receptor. Listen, what will happen now? And how many molecules of acetylcholine is required to open these receptors? Each receptor. Because it has got two alpha subunits, one beta, one epsilon, one delta. How many molecules of acetylcholine is required to open these receptors? Two alpha receptors, subunits are there. It requires two molecules of acetylcholine.
Acetylcholine. Okay.
Acetylcholine has to bind to both the alpha subunits.
Both alpha receptors.
Then only the channel will open or the receptor will open up. If only one subunit is alpha subunit is associated with acetylcholine, it cannot open. Whereas non-depolarizers, they will also occupy these alpha subunits. If they occupy one molecule of non-depolarizer occupying one alpha subunit, even though acetylcholine occupies the other subunit, it cannot open the channel. I hope you have understood.
Yes,
Yes,
sir.
sir. Yes, sir.
Because there are two alpha subunits, both the alpha subunits have to be occupied by acetylcholine.
Acetylcholine.
Then only the channel will open. If only one subunit is occupied, alpha subunit is occupied by acetylcholine, other subunit is occupied by non-depolarizer, the channel will not open.
Okay, sir.
That shows that, the non-depolarizer definitely will be more potent than acetylcholine. It can block only one subunit, alpha subunit, and prevent, channel being open. So that is another very important aspect of this, the anatomy of the receptor, nicotinic receptor at the motor end. Now, once the acetylcholine two molecules act on these two alpha subunits, the channel is opened. What next? What happens now?
There is continuous depolarization.
Depolarization.
Now, depolarization has. What do you mean by depolarization? What happens to these electrolytes? They produce change in the transmembrane potential or electrical potential or the end plate potential.
Potassium also comes in. The
What happens?
potassium
Potassium has to.
Come out.
release.
It is, sodium has to enter inside, potassium has to.
Potassium has to
Potassium
come out.
channels. So potassium comes
Potassium
out.
comes out, sodium enters. Usually the resting membrane potential is minus 90 millivolt. Now the transmembrane potential starts increasing. So the depolarization in electrical current is formed there. Voltage is created, isn't it? It can even reach +1 from minus 90, isn't it? So once this electrical current is or voltage occurs, this voltage, gets transmitted across the muscle membrane. So once the voltage, goes across the muscle membrane, what it does, what does this voltage that is created at the neuromuscular junction at the motor end plate, what it does to the whole muscle?
So
Causes continuous
contraction.
contraction.
How contraction occurs? How this electrical signal then, it has to get transmitted to chemical signal to produce something. How this happens? These are all the
So
basic anatomy.
contraction excitation couplings.
How it occurs? Excitation, contraction, coupling between. Now this electrical signal that is, voltage that is created, it is transmitted through transverse tubules. So these transverse tubules carry this electrical signal into the inside of the muscle membrane, where there is sarcoplasmic reticulum will be there, which holds calcium. And the calcium gets released from the sarcoplasmic reticulum. And calcium will bind to troponin. Normally, you have actin and myosin
Active
filaments.
myosin fibers.
So the actin filaments cannot move on the myosin filaments because it is bound by troponin. Now the troponin has to release actin filaments. So calcium has to go and then bind to troponin to release actin filaments so that actin filaments can slide over myosin filaments to produce contraction. This is called as, contraction uh, coupling, what we just now said. Contraction excitation coupling. So the calcium that is released from the sarcoplasmic reticulum will go and bind to troponin. It releases actin filaments so that actin filaments can slide over the myosin filaments and a contraction occurs, isn't it? Now, what is happening to these acetylcholine molecules that are bound to the alpha subunits? They cannot bound to alpha subunits for a long time. They immediately get released, isn't it?
Yes.
They immediately have to get released. So they get released, and part of the acetylcholine that is again released is also acted upon by, as you said, in the synapse, you have a specialized, enzyme is there that is acetylcholinesterase. Acetylcholinesterase acts on this acetylcholine, and then it metabolizes acetylcholine to acetic acid and choline. And this choline is again taken back into the nerve ending. And with the help of acetyl-CoA, which is produced by the mitochondria inside the nerve ending, it forms again the acetylcholine. Acetyl-CoA, acetyl-coenzyme A plus the choline combine to form the acetylcholine. And it is mainly that occurs inside the nerve ending. And again, this acetylcholine that is formed is stored in the vesicles. Isn't it? Now,
Yes.
as soon as these acetylcholine is released from the immediately available stores, now again, the reserve stores have to move towards the immediately available stores because they are exhausted now, isn't it? How this movement occurs from the reserve pool to the immediately available pool of the vesicles, that they can fill again for the next contraction. They have to be available immediately so that acetylcholine can get released into the synapse.
Sir, with the help of ATP and hydrogen ions.
Mhm. So what receptors are required again to be activated now?
SNAR proteins.
So what receptors are present? Nicotinic receptors that are present at the nerve ending. Motor end plate, you have specialized receptors. They are, pentameric structure, the 2 alpha, 1 beta, 1 delta, and 1 epsilon. There are nicotinic receptors at the nerve ending also. And what are these? receptors at the nerve ending. What kind of nicotinic receptors there? There are alpha 3 beta 2 receptors. Everything is there in your barrage. I am not telling from something else from anatomy and physiology. No, it is there in barrage only. It is there in Miller. It is there in every book. If you read it, I think in the beginning only it is there in barrage. Alpha 3 beta 2 receptors that are present at the nerve ending. And these alpha 3 beta 2 receptors are again stimulated by the released acetylcholine. They get, acetylcholine not only acts on the receptors at the motor end plate, it also acts on the presynaptic receptors, this alpha 3 beta 2 receptors. Once it acts on the alpha 3 beta 2 receptors, so it immediately sees that the reserve pool of acetylcholine moves towards the immediately available pool, so that it is concentrated there. For the next signal, once it comes, again acetylcholine is ready to be released. For that movement, the alpha 3 beta 2 receptors are very important. They have to be acted upon. And why, as an anesthesiologist, you should know about this alpha 3 beta 2 receptor? What is the importance? What is its importance, these alpha 3 beta 2 receptors? Very important again for pharmacology of the non-depolarizing muscle relaxant. So non-depolarizing muscle relaxants produce fading of this tynophore or tetanic response. They produce fading. That is the basic difference between a depolarizer and a non-depolarizer. And these non-depolarizing muscle relaxants not only block the postsynaptic receptors, they also block the presynaptic alpha 3 beta 2 receptors. Once these receptors are blocked, now what is their function? I just told you. What is the function of alpha 3 beta 2 receptors?
To from reserve to
To
immediately
mobilize the
mobilize the
acetylcholine from reserve pool to the immediately available pool. So if they are blocked, what happens now?
you won't have the reserve
You don't have the reserve. You don't have the movement of the
movement of
acetylcholine from the reserve to the immediately available. Now, even if a signal is there, the release of acetylcholine will be very much decreased, isn't it? Because enough is not available at the nerve ending for immediately to be
release.
released. So what happens to the next, stimulus? It will be reduced, isn't it? The activity will be much less. If you have a train of four, then the amplitude of the train of four starts decreasing. And this is called as fading.
Fading.
You must have read about this fading things. And fading does not occur with depolarizers. Fading occurs with non-depolarizers.
Non-depolarized.
And that is because non-depolarizers act on the presynaptic alpha 3 beta 2 receptors, block them so that the movement of the acetylcholine from the reserve pool towards the immediately available pool will be decreased. That is another very important thing. Okay, normally I told you that the calcium enters the nerve ending and then helps in release of acetylcholine, isn't it? Now, how this action is curtailed? Because it cannot continuously keep on releasing acetylcholine, isn't it? It has to stop. How this effect of calcium will be stopped? What produces this stopping of the effect of calcium? It is the opening of the potassium channels at the nerve ending. The potassium will, immediately block the calcium channels. Entry of potassium will block the calcium channels so that, further release of acetylcholine will be stopped. So muscles have to relax. They cannot have a sustained contraction, isn't it? So that's why there has to be a negative feedback also. So once the calcium enters, releases acetylcholine. Afterwards, potassium enters, and it immediately blocks the calcium channels,
Calcium
so
channels.
that further release of acetylcholine will not occur, and the muscles will start relaxing. So that's how it's very useful. And what are the other important factors which can influence these calcium channels, so that the release of calcium, the entry of calcium is decreased and release of acetylcholine can be decreased? What other anesthetic implications of this particular mechanism? Very important for us again during anesthesia. I'll give a clue also. Let us say that preeclampsia, severe preeclamptic woman is being treated with magnesium sulfate. What is the effect of magnesium sulfate on the neuromuscular junction?
It prolongs the
Now, what is the effect of magnesium on the neuromuscular junction?
magnesium on neurons.
Magnesium blocks the calcium channels. So because magnesium blocks the calcium channels, release of acetylcholine will not occur, even though there is an electrical signal. That's how there is flacidity of the muscles. That's how your what happens is your deep tendon reflexes are lost, and then the respiratory muscles will be paralyzed with magnesium later if toxicity occurs. That is why when you're using magnesium sulfate for these preeclamptic women, it is very important. You have to monitor the deep tendon reflexes. Once the deep tendon reflexes are lost, you know that the patient is going in for magnesium fatigue. So that you'll have to stop the magnesium infusion. So that is very, very important. So continuous monitoring of the ECG, continuous monitoring of the deep tendon reflexes and the urine output are very important when you are using magnesium sulfate for preeclamptic women, because it can produce. You must have known about many times the magnesium, when you give more, it can even produce respiratory arrest for these
Yes.
preeclamptic mothers. So once it crosses 10 uh, micrograms per ml, it produces abolition of deep tendon reflexes, and 15 micrograms, I think the power has gone. Are you able to hear, Siddharth? Hello? Why power frequently will be cut in Pondicherry, I think. Power cut. Power cut was there, is it? You are able to hear me? Able to hear me or not? I am able to see you people. Siddharth, you are able to hear me? I am not able to hear you.
You're unable.
Now I am able to hear you. Yeah. Okay. Now you see, magnesium will block these calcium channels so that acetylcholine is not released. That's how it can produce paralysis. Anything about 10 micrograms per ml produces deep tendon reflexes abolition, and 15 micrograms definitely can produce dysrhythmias. 20 micrograms can produce respiratory muscle paralysis. Same thing like, we were talking about lidocaine, and 25 micrograms cardiac arrest with magnesium sulfate also. So that is mainly because magnesium acts on these calcium channels and block the calcium entry inside. Once the calcium entry is inside is blocked, acetylcholine cannot be released. That's how the tone of the muscles is decreased. That's how it produces quite a bit of muscle relaxation also, magnesium sulfate. So that is very important. Nowadays, in many of the times, even magnesium sulfate is being used as a pre-medicant drug by many anesthesiologists to suppress the intubation response. And also it is an NMDA receptor antagonist. It produces by itself analgesia, and the requirement of other anesthetics will decrease throughout. So that's how magnesium sulfate is being used as a pre-medicant, a pre-induction agent by many anesthesiologists. I've heard so many anesthesiologists telling me, sir, I'm using magnesium sulfate along with midazolam and dexmedetomidine and fentanyl, so that my requirement of anesthetics intraoperatively will come down. But when you give magnesium sulfate, you have to monitor the neuromuscular junction, because the magnesium will potentiate the effects of non-depolarizing muscle relaxants. So that you should always realize. So that is why the effect of magnesium on the calcium channels is very important. So you should always know. Is there any syndrome which directly produces antibodies to these calcium channels? Is again important for us, wherein the release of acetylcholine at the presynaptic nerve ending is decreased, and the patient can have weakness of the muscles. Any
GBS
syndrome? Not GBS.
or Duchenne
No. That is entirely different. That is muscular dystrophy. It almost resembles myasthenia gravis, but not myasthenia gravis. You have to differentiate myasthenia gravis with that particular syndrome.
here you go.
It is called as Eaton-Lambert syndrome.
Eaton Lambert syndrome.
Eaton-Lambert syndrome, or otherwise called as myasthenic syndrome.
Myasthenic syndrome.
Myasthenic syndrome. In Eaton-Lambert syndrome, these antibodies are formed for these calcium channels, and calcium channels gets destroyed. And once the calcium channels are destroyed, calcium entry inside will not be occurring. So release of acetylcholine is decreased. That's how these patients will develop muscular weakness, isn't it? Whereas myasthenia gravis, it is antibodies are found for the postsynaptic receptors. Postsynaptic nicotinic receptors are destroyed by the antibodies in myasthenia gravis. That is the difference. Myasthenia gravis, it is always the postsynaptic problem, whereas Eaton-Lambert syndrome is a presynaptic problem, where calcium channels are destroyed because antibodies are there for the calcium channels, and that's the reason why acetylcholine cannot be released. So that is the difference between Eaton-Lambert syndrome and myasthenic syndrome. Of course, other differences are there, like Eaton-Lambert syndrome, more common in males. Myasthenia gravis is more common in females. Eaton-Lambert syndrome is more common in, older people. And invariably, majority of these patients can have malignancies, and it can be a problem of a malignancy, Eaton-Lambert. Whereas myasthenia gravis occurs in younger individuals, younger females, and it is an antigen antibody, autoimmune disease, myasthenia gravis, and invariably these patients may also have a Graves' disease also, myasthenia gravis patients. So there are differences are there, like your anticholinesterase actually help in myasthenia gravis patients, whereas anticholinesterase will actually produce more paralysis in patients with Eaton-Lambert syndrome. That is why the management entirely is different. So you have to understand about the differences between Eaton-Lambert and myasthenia gravis. Now you have understood about the importance of calcium channels in the presynaptic nerve ending, the importance of alpha-3 beta-2, nicotinic receptors in the presynaptic nerve ending. I hope you have understood the whole thing, isn't it? So
Yes.
that's how, a muscle contraction occurs. And that is the importance of these receptors, nicotinic receptors. And postsynaptic receptors, again, you have a fetal type, or otherwise also can occur in adults also, where there is a denervation occurs and there is extrajunctional receptors are formed. And what is this upregulation and downregulation of these receptors? When this upregulation can occur and when downregulation can occur? When the receptors can increase and when receptors can decrease. That is what is upregulation and downregulation of receptors. Again, it is very important for us to know anesthetic implications are there. Whenever there is a denervation, upregulation occurs. Whenever the nerve, nerve or upper motor neuron disease or a lower motor neuron disease occurs, so that produces the denervation for the muscle fibers. Then the body tries to increase the number of receptors, and this is called as upregulation or denervation supersensitivity. It is called as denervation supersensitivity or upregulation. And whenever there is an upregulation, it is always the extrajunctional fetal type of receptors that are formed. Whenever there is a denervation occurs. So that you should always realize. And when downregulation can occur, when the number of receptors can come down,
Neuron injuries.
when they are, repeatedly stimulated, when there is no stimulation, their upregulation will occur. Whenever there is denervation. When they are repeatedly stimulated, so there can be downregulation. When this can occur, when they can be repeatedly stimulated or
Phase 2 block.
Phase
Phase 2
blockade.
blockade.
no. They, this occurs, downregulation occurs whenever a myasthenia gravis patient is being treated with anticholinergics like neostigmine or pyridostigmine. So this will increase the amount of acetylcholine in the neuromuscular junction. And there is repeated stimulation of these nicotinic receptors. As such, the nicotinic receptors would have come down whenever there is myasthenia gravis is there, because an autoimmune reaction, antigen antibody reaction there, and destruction of the new receptors are already occurred. When a prolonged stimulation is occurring by using anticholinergics, the number of receptors will further come down. That is the down regulation that occurs. Okay. One more thing about the basic calcium channels in the presynaptic nerve ending. What type of calcium channels are these? Because there are two types of calcium channels. One is the slow calcium channels or L type that are there in the heart. And this one fast calcium channels which are called as the P channels, L channels and P channels. So what type of channels are present at the motor nerve ending?
P channels.
They are present P
Constant.
channels. And
P
as
channel.
an anesthesiologist, why should you know, Siddharth? Why should you know that P channels are present there and not the L channels, L type of channels?
For faster transmission.
Why should you know that there are not slow calcium channels, they are the fast calcium channels, or they are the P type, not the L type. L type may also be there, but majority of them are P type. Because I give you a clue for answering this question. The patient is on a calcium channel block, like patient may be on verapamil,
Verapamil, diltiazem.
diltiazem. So what is their effect on these calcium channels? Will they have any effect or they don't have any effect? If they have an effect, then there will be, a potentiation of the effect of non-depolarizing muscle relaxant, isn't it? Because acetylcholine will not be released because they block the calcium channels at the nerve ending because they are calcium channel blockers.
So they will not have.
They are actually slow calcium channel blockers. Their main effect is on the L
L type.
channels and not on the P type of calcium channels.
Okay, sir.
That is why even though patient may be on low calcium channel blockers, the effect is minimal. But there are incidences where they have prolonged the duration of action of non-depolarizing muscle relaxants. So this you have to keep it in your mind. If the patient is on, you know, slow calcium channel blockers, there is always a possibility that they may slightly prolong the duration of action of non-depolarizing muscle relaxants by acting on these calcium channels, fast calcium channels, calcium channels. Though their effect is mainly on L type, they may also have some amount of effect
Action.
on the P channels as well. So that is why you should know about this anesthetic implication is always there. Okay. Now, again, the muscle types are also different muscle types are there based on the effect of the muscle relaxants on these muscle fibers. What are there are three groups of muscles fibers. Actually, you classify, again, very important, before you know how these muscle relaxants will act on different muscle groups. So how do you classify these muscle groups based on the action of these non-depolarizing and depolarizing muscle relaxants on these muscle groups?
Skeletal, smooth, and cardiac muscle. And, smooth muscle that will not act. So,
No, if you're telling, you tell it loudly.
நீ சொல்லு correct. She says skeletal, smooth,
skeletal
and
and
cardiac
cardiac
muscles,
muscles, but it will not act on us.
I'm talking about only the skeletal muscle.
fibers.
I'm not talking about muscle groups, skeletal muscle groups. Now you have various muscles, isn't it? You have diaphragm, you have adductor muscles of the larynx, you have masseters, you have corrugated superciliary of the eyes, you have peripheral muscles. The different muscles groups are there, isn't it? So when you give a muscle relaxant, which group of muscles will, first get affected? Is it,
Starting from
you can easily classify them even as the central group of muscles and peripheral group of muscles. Central group of muscles, you have the diaphragm, you have the adductors of the larynx. Why I'm telling about the adductors of the larynx is unless the adductors of the larynx are relaxed or blocked, you cannot intubate, isn't it? Once the adductors are blocked, now the vocal cords will be abducted,
Abducted.
easily intubate. So the adductors of the larynx have to be blocked. The diaphragm has to be blocked because you want the patient not to breathe so that you can control the ventilation.
so it's from central to periphery, sir.
So these are the central group of muscles, plus the masseter, because the masseters have to be relaxed for you to open the mouth, and airway muscles they have to be blocked for you to do a proper laryngoscopy and intubate. So then your eye muscles, that is extraocular muscles, your corrugated supercilii, and then your peripheral muscles. And the peripheral muscles which you are always monitoring, which peripheral muscle you always monitor?
The foot and the hands.
No, usually the hand. I don't think anytime you have monitored a foot. I never,
Only the hands.
only when both upper limbs are amputated or upper limb surgery is being done, then only you can monitor the foot. Otherwise, which muscle is the most popular muscle to be monitored? Nerve,
Hands.
The
Hands.
thenar
adductor pollicis,
adductor pollicis.
ulnar nerve and the adductor pollicis. These are peripheral group of muscles, isn't it? So, which group of muscles get blocked first? Is it the
Central.
central group of muscles or it's the peripheral group of muscles?
Central to periphery.
Central group of
Central to
central to
periphery, sir.
periphery.
The why central to peripheral?
Uh, Sir, usually when we give saksa, we wait.
No, whether you give hexametonium or whether you give vecuronium or racurium,
No, sir.
hardly matters. So you said that central group of muscles will get blocked first. Why? Why not peripheral group of muscles? Which group of muscles gets the drug first? Which are very close to the heart,
Heart
Central.
central, sir.
isn't it? That is very logic, isn't it? The basic thing. Because the blood first, goes to the central group of muscles because they are very close to the heart. and then the blood has to reach the peripheral group of muscles. That is why the first group of muscles which gets the drug first gets blocked first. That is why the central group of muscles will get blocked first, and then the peripheral group of muscles will be blocked next. And again, these muscles are subclassified as other than central group and peripheral group, the resistant muscle group, and then highly sensitive muscle group. Which are the muscle groups which are highly resistant to the action of neuromuscular blocking agents?
Cardiac.
Smooth
Cardiac
muscles.
muscles
Smooth
are
muscles.
skeletal muscles.
Nice.
Now I told you you have diaphragm, you have adductor muscles of the larynx, you have eye muscles, you have masseter, you have airway muscles, you have peripheral muscles. Which group of muscles are highly resistant to the effect of non-depolarizers?
Smooth muscles, sir.
அப்படில்ல.
And your muscle relaxants act only on skeletal muscles, madam, not on the smooth muscles. Why are you getting confused?
அது
I'm
சொல்லுங்க.
telling you also, these are the groups of muscles. You have diaphragm, you have adductor pollicis, that is the peripheral muscle, and adductors of the larynx, and you have eye muscles, the masseter, the airway muscles. So, which are the muscles which are highly resistant? Which are the muscles which are highly sensitive to the effect of neuromuscular blocking agents? And why you should know this? Everything has got an anesthetic implication. It is not just like that. You have to know. You have to know in detail about these. Unless you know about these things properly, so you will not understand the pharmacology of neuromuscular blocking agents.
The uh, adductor group and the diaphragmatic muscles, they are more sensitive when compared to
You are telling the opposite. They are highly resistant muscles. I am okay. Let me answer you. No, you can classify these based on their sensitivity and the onset of action. You have the diaphragm, you have the adductors of the larynx, you have the masseter, you have the corrugator superciliary. These four groups of muscles, the central muscles, the diaphragm, the adductors of the larynx, the masseters, then you have the corrugator superciliary, the eye muscle. Then you have the airway muscles, which maintain the patency of the airway. Airway muscles, which maintain the patency of the air. They are again central group of muscles. Then you have peripheral muscles. Okay, so they can be classified as muscles which are highly resistant, but their onset of action is very fast. Muscles which are highly resistant, but onset is fast. Okay. The second group of muscles, they are highly sensitive, onset is fast. And third group of muscles, highly sensitive, but the onset is delayed. Now, I hope you have understood three groups of
yes,
muscles,
sir.
how you
Yes.
classify. Highly resistant muscles, but onset is very fast. Highly sensitive muscles, onset is very fast of
Fast.
these muscle relaxants. And third group of muscles, highly sensitive muscles, but onset
But it's
delayed.
delayed.
Now, highly resistant muscles and the onset is being very fast is, you have the diaphragm, you have the adductor pollicis, adductors of the larynx, the masseter, corrugated superciliary. These four group of muscles are highly resistant muscles, and the onset of action is very rapid. Now, the second group of muscles, I said, the highly sensitive muscles, even a small amount of muscle relaxant is enough to block and produce paralysis. Highly sensitive muscles, where action is very fast, onset of action is very fast. These are airway muscles. Airway muscles. The third group of muscles are where highly sensitive, but action is delayed, is peripheral muscles, where we monitor. Now, why should you know about this particular thing? Why should you know that the diaphragm is very resistant? The adductors of the larynx are very resistant muscles. Why should you know that these are highly resistant muscle groups? Highly resistant means what? Resistant to the effect of, your muscle relaxation. That means the dose that is required is higher or lower to block.
Higher,
Higher, sir.
higher.
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 The dose that is required to block these is much higher when compared to the dose of the drug that is required to block the airway muscles and the peripheral muscles. That is why the concept of ED95 is there. Whenever we talk about the potency of a drug, we always talk about ED95. What do you mean by ED95?
It is the
Effective
effect
dose.
of 95 percentage to suppress the single twitch of a supramaximal stimulus.
Very good. So it is the dose, effective dose, that is required to decrease the amplitude of the single twitch response by 95%.
Percentage.
Yes.
That is the dose required to decrease the amplitude or the height of the single twitch response by 95%. That is in 50% of the patients. That is called as
Yeah.
ED90.
95.
So you should know about ED95 of all the muscle relaxants. But when you give the muscle relaxant dose, initially, if you want to intubate a patient, how much of ED95 you have to give? Is it the ED95 is enough, or twice the ED95 you have to give? How much the intubating dose? Always we always call it as
Intubating dose will always be thrice of the ED95 dose.
minimum is twice.
Minimum
Twice.
is twice.
Now why should you give twice? Now you have understood about resistant muscles, sensitive muscles, and all those. Why
Yes.
should you give twice the ED95?
To reduce the stimulus.
Because the peripheral muscle group is highly sensitive,
But you don't
and
require a high dose for that. You require ED95 is enough.
So, but
ED95
the
is enough only
resistant
for
muscle,
peripheral, but
Yes, very good.
for the
resistant muscle,
central you need a higher dose because they are more resistant, so you
Ah,
need a higher dose.
higher
So
dose.
the
So double
ED95
the
is
dose.
enough only for the peripheral, but to suppress the response of the central muscles which are more resistant, you need twice or thrice of that of.
now you understood why should you know about this resistant group of muscles, sensitive group of muscles and all. So
Yes.
that is why, intubating dose is always we give twice the ED95.
Yes.
That is very important to understand. Suppose if the patient has already been intubated, now you have to give the first non-depolarizing muscle relaxant dose. How much is should be the dose you have to give? Already patient is intubated. You need not have to again paralyze these resistant muscles. Already patient, you have already put a tube. Your adductors of the larynx have been paralyzed and you have placed a tube. You have used succinylcholine to do this. Now you have to give the first dose of non-depolarizing muscle relaxants.
ED95 doses.
Yeah, that ED95 dose is enough to maintain the paralysis. So for that, you have to know the three groups of muscles. One. The second thing is you must have seen at the end of surgery, patient will be bucking and he'll start breathing. Why he'll start breathing and bucking? And should you extubate the patient by that time? You have not even given neostic min. Already the patient will be breathing many times and he'll not be tolerating with you. Why that is?
The depth is inadequate.
ಇಲ್ಲ, ಇಲ್ಲ. That is because the ಏನು sir?
Dose that is there at the neuromuscular junction at the
Junction.
diaphragm and adductor policy is not enough
Enough. Okay.
to block because they require a very high concentration of the drug to block the or to produce paralysis of diaphragm and adductor policies. The, after some time, the concentration will start decreasing.
Yes, sir.
Reducing.
So it
And
has to.
concentration is not enough to produce paralysis of the diaphragm and adductor policies. If adductor policies is now recovering, patient will not tolerate the tube because it tries to contract,
Contract.
bring the vocal cords adducted, and the diaphragm will start, the patient will start breathing because the diaphragm is free now. isn't it? But the airway muscles, which are very sensitive, still will be under the influence of non-depolarized
Paralyzing agent.
because
Okay.
they are very sensitive. The concentration that is required to block these muscles is very, very minimal. So, but if you just take out the tube, because the tube is there, the patient is able to breathe. If you take out the tube, there is airway collapse. And patient will not be able to breathe. He'll go for hypoxia, hypercarbia, and all the problems, isn't it? So that's why you have to make sure that these airway group of muscles are also completely not under the influence of the neuromuscular blocking agents because they are highly sensitive group of muscles. That is why many times, unless you monitor, you will not know whether the airway muscles are free or not. And many times you think that the patient is not tolerating the tube and he is breathing, and you just see the bag, you think that adequate tidal volume is there, and you extubate the patient, immediately there is this airway collapse. I've seen many of the inexperienced anesthesiologists extubating the patient, immediately followed by airway collapse. And this airway collapse will produce an obstructed airway. And many times I've seen even the patients developing negative pressure pulmonary edema. And immediately the pulmonary edema occurring. And sometimes even you can lose the patient. That is why this knowledge about the resistant muscles, highly sensitive muscles is very, very important. So we'll discuss about these things later when we discuss about neuromuscular monitoring also. But these three group of muscles are very, very important for us to know. Now coming to actual, after these, all these, some of these anatomy and physiology of these different neuromuscular junction and the receptors and different channels and also different group of muscles. Now, actually, we can start talking about the pharmacology of these neuromuscular blocking agents. So, how do you classify these neuromuscular blocking agents?
Basically into depolarizing and
Very
non-depolarizing,
good. So,
and
depolarized and
non-depolarizing into long acting, intermediate acting, and short acting.
that is based on the duration of action. Based on the structure,
Based on structure.
two groups are there. What is the two groups of NDMRs, non-depolarizing muscle? They are aminosteroids
Ah,
and benzyl amino
benzyl
Minus.
quinolonium.
quinolones,
Yeah, benzyl
benzyl,
amino
benzyl
quinolonium
tetrahydroaminoquinones.
quinolonium group of drugs, isn't it?
Group of
On
drugs.
the structures, you have aminosteroids and benzyl aminoquinolonium group of drugs, and based on the duration of action, so short acting, intermediate acting, and long acting. Can you give examples for depolarizers?
Depolarizing
Succinylcholine.
is succinylcholine and
And
another decamethonium.
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 Yeah, succinylcholine and decamethonium.
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 Decamethonium was more potent when compared to succinylcholine and long. It was slightly longer duration of action. Why decamethonium we are not using now? Why only succinylcholine is being used? Why not decamethonium? That is why succinylcholine is also other name for succinylcholine, succinylcholine,
Saxamethonium.
Saxam.
succinylmethonium and decamethonium. Why decamethonium has been withdrawn? Lot of histamine release. It used to produce lot of histamine release. That's why all the problems associated with histamine used to occur. That's why decamethonium has been withdrawn. Now we have only succinylcholine as a depolarizing muscle relaxant. Now coming to non-depolarizers, can you give examples for aminosteroids? The first aminosteroid that
Um,
was introduced,
Vecuronium
the first
is
aminosteroids that was introduced, I told you in 1963, I told in the beginning of my discussion,
1963.
pancuronium.
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 Isn't it? I told you the first aminosteroid
Yes.
Because what is DTC? DTC is what? What group of drugs? It's
The
benzyl isoquinoline group of drugs. D-tuberculin. So you have aminosteroids. What are the different aminosteroids? One is pancuronium, then
Vecronium,
picronium,
Piprochironium,
pipecuronium,
Pipecuronium, and Rocuronium.
rocuronium, and rapacuronium. Out of these, we use nowadays pancuronium, vicuronium, and rocuronium.
Rocuronium.
Pipecuronium is not used. It's a long-acting aminosteroid. And rapacuronium also we are not using because it used to produce a lot of bronchospasm, rapacuronium. So that's why it was withdrawn. We have only vicuronium and rocuronium. And then we have benzyl isoquinoline group of drugs. Can you give examples for these?
Mevacurium,
Yes, mevacurium. DTC, I told you.
DTC, Mevacurium, Atrac, and Cisatrac.
Atracurium and cisatracurium.
Cisatrac.
So these are benzyl isoquinoline group of. And you said that short acting, intermediate acting, and long acting. Can you give examples for short acting group of drugs?
Mevacurium and Cantacurium.
Gentacurium, of course, we are not using it. So,
Mevacurium.
yeah, mevacurium, of course, you can say gentacurium, and also succinylcholine.
Succinylcholine.
In broad,
In broad.
shall classify as short acting, intermediate acting, and long acting. Short acting are your succinylcholine and your mevacurium or short acting. If you are classifying only non-depolarizer, short, intermediate, and long acting, then you have, mevacurium is short acting. Intermediate acting group of drugs.
The Vecronium,
Vecuronium,
Rocuronium,
rocuronium.
Pancuronium.
No.
Pancuronium is a long acting.
Atracurium.
Atracurium,
Tetracurium.
Cisatracurium.
These are all intermediate.
Intermediate.
Okay, long acting.
Pancuronium and
Pancuronium, DTC,
DTC, Pipecuronium.
galamine triethiodide. These are all because we have extensively used DTC and galamine. So we did not have vecuronium because vecuronium was introduced in late 1980s. We did not have. So pancuronium was very costly during those days. It was 20 rupees per ampule. And 20 rupees was too much for buying during those days. It was probably like 2,000 or 3,000 rupees. Now also I think pancuronium is 20 rupees only. Even now it is one of the cheapest non-depolarizing muscle relaxant. Of course, vecuronium was not available, rocuronium and not introduced at all. So we used to use galamine. Galamine was very, very popular. I don't think you have even heard of galamine triethiodide. So DTC, galamine were very popular. And later, of course, pancuronium. Special patients like cardiac patients and all, we used to get pancuronium and we used to use. Of course, now it's hardly being used. It's used by cardiac anesthesiologists because what is the problem with long-acting muscle relaxants compared to intermediate acting?
Delay in
Something called as a residual neuromuscular palsy because
curarizing.
long-acting drugs are cumulative. And even in the postoperative period, there is a release of these molecules into the blood, and they could produce a residual neuromuscular palsy. If the effect of the neuromuscular blocking drugs extends into the postoperative period and continue to produce some amount of paralysis, especially of the airway muscles, which are highly sensitive, you call it as residual neuromuscular palsy. And this residual neuromuscular palsy can only be detected by what? How you detect residual neuromuscular palsy? Can only be detected by
TOF.
a quantitative monitor.
Quantitative.
a quantitative monitoring of TOF ratio. Unless the Train-of-4 ratio is nearly 1 or above 0.9, if it is between 0.4 to 0.9, any of the subjective methods, by you always say that, open the eyes, protrude the tongue, sustained head lift for more than 5 seconds, sustained leg lift for more than 5 seconds, sustained hand grip of more than 5 seconds. All these are subjective signs of neuromuscular recovery, or will not be able to find out whether there is residual neuromuscular palsy is there or not. If the Train-of-4 ratio is monitored, and if it is above 0.9 and nearly 1, now then only you can say that the patient doesn't have any residual neuromuscular palsy. But most of the time we don't monitor. That is why, it has been said that 40% of the postoperative patients can have residual neuromuscular palsy. You can imagine the extent, 40%. And if the patient is fortunate, he may not have much problems. And especially those patients who are extremely morbidly obese or critically ill, and who also already have some neuromuscular disease, these are the highly vulnerable patients. And they can develop all kinds of postoperative pulmonary complications, and they can even die. That is why the residual neuromuscular palsy detection is very important. This is a short notes for you. Residual neuromuscular palsy, and what it is, and why it occurs, how it can be detected, what are the consequences of residual neuromuscular palsy, and especially the effect will be on the highly sensitive airway group of muscles, because the diaphragm would have recovered, the adductors of the larynx would have recovered, because they're resistant muscles. But airway group of muscles, even a small amount of residual effect is there of neuromuscular blocking agent, they can, have less activity or less tone and airway collapse. That is very common with residual neuromuscular. So can have deleterious effect on the patient. That is why you should know about this residual neuromuscular. So the long-acting drugs are notorious to produce this residual neuromuscular effects because they're highly cumulative, whereas it is less common with intermediate acting and short acting drugs. That is why we nowadays we go with intermediate acting and short acting drugs rather than long acting. I told you cardiac anesthetists still use the pancuronium, which is a long acting drug, because many of these cardiac surgery patients are post-operatively mechanically ventilated. They're not extubated on tape. Majority of them are, prophylactic mechanical ventilation is done, and afterwards only they are, extubated, maybe for 24 hours and all.
We also follow the same here, sir.
Yeah. So that is why pancuronium can be used, because very cheap drug and can have prolonged duration of action. So, and anyway, you are not bothered about residual neuromuscular palsy in the postoperative period, because patient is having a tube, he is being ventilated. So you need not have to worry at all. Isn't it? And many times even pancuronium can be used in mechanically ventilated patients in ICUs. There also, you require a longer acting drug, so can be used. So these are the indications for longer acting drugs. Otherwise, routine anesthesia practice for non-cardiac surgery patients, and where you want to extubate the patient on table, now we are using either vecuronium or rocuronium or, atracurium or cisatracurium. So these intermediate group of neuromuscular blocking agents are more popular. Listen. So now we will have to discuss about these individual drugs, succinylcholine, and then non-depolarizing muscle relaxants, then neuromuscular monitoring, then reversal agents. So we'll discuss in our next class on next Friday.
Sure,
So
sir.
Friday, I think we should be able to
Yes, sir.
of neuromuscular. I want you to read more and then come
Sure,
Okay,
sir.
sir. Sure.
about this. Today only you go and read about basic anatomy and physiology of neuromuscular junction.
Yes, sir.
Yes, sir.
Don't
Sure, sir.
read today only because we have done extensive discussion. If
Yes.
you
Yes,
read
sir.
today, you will understand it better.
Yes.
Sure,
If
sir.
you
Sure.
have any doubts, definitely we can discuss in the beginning about the any doubts regarding this neuromuscular anatomy and physiology in our next class, and then go for depolarizers and non-depolarizers individual and factors
Yes.
influencing the block and neuromuscular monitoring, and will complete whole neuromuscular pharmacology, physiology, anatomy, pharmacology, everything.
Yes.
Yes, sir.
Okay. Any doubts for anybody for today's discussion? Your friends also. Any in the chat box, anything in the chat box?
No, sir.
Yeah, there is hardly anything in the chat box. Regarding magnesium, he has written, I think, prolongs.
So when you asked why, what happens when
Yeah.
magnesium is given in preeclampsia patient, he has answered that question.
So now you know why magnesium, how it produces prolongation of the non-depolarizing muscle relaxants, because there is a competitive antagonism between acetylcholine and non-depolarizing muscle relaxants, isn't it? That is what is the type of block they produce. And to produce the block and prolongation, it if the amount of acetylcholine is less, there can be prolongation of the effect. So
Yes.
because magnesium acts on the calcium channels and decreases the release of acetylcholine, so the competition, the ratio will be more towards the non-depolarizers than towards the acetylcholine. The levels of acetylcholine will be much less when compared to non-depolarizers. So that's how the prolongation of the effect of non-depolarizers occurs with magnesium. So that is the reason you have to be extremely careful with magnesium. By itself, it can produce paralysis if the toxic doses are there. By totally blocking the calcium channels, not releasing any acetylcholine, and acetylcholine is required for depolarization and the motor endpoint. It has
Yes.
to occupy the 2 alpha receptor subunits, isn't it? So unless it occupies, unless acetylcholine is there, the contraction will not occur. So it can block all the calcium channels and then totally deplete the neuromuscular junction with acetylcholine and can produce respiratory paralysis and death also can occur. That's why you have to be extremely careful when you're giving magnesium sulfate. Ideally, neuromuscular monitoring should be done. So routinely, we don't do in the labor room and all when these patients are given magnesium sulfate. At least deep tendon reflexes have to be checked. If there is any decrease in the briskness of the deep tendon reflexes, you know that patient is going in for
Magnesium has
magnesium.
toxicity.
Ideally, you can even check for the plasma levels of magnesium. That also can be done. But every laboratory may not have the provision for the assessment of the magnesium concentration. So then at least deep tendon reflexes have to be monitored. Okay, any doubts regarding this today's discussion with anybody else or for you only? Any doubt? You understood whatever we discussed?
Yes.
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 So I want you to read again today, because
Yes.
today only if you read, you will understand better.
Yes, sir.
And
Yes.
again, next Friday we will meet.
Sure,
Yes,
sir.
sir. Sure, sir.
Okay, Siddharth and Jasmine.
Thank you, sir.
Okay,
Thank you, sir.
okay.
Thank you,
Good
sir.
evening, sir. Thank you,
Thank you,
sir.
sir. Thank
Thank
you,
you so
sir.
much.
Bye, good night.
Good night, sir.
Good night, sir.